their learning journey. Fantastic. I think we've got some past students here with us today. So if anyone would like to take the opportunity to chat towards the end, you're more than welcome to. You'll be more than welcomed. Now, we also have practicing classical osteopaths who were osteopaths and they came and joined the institute. They did the postgraduate diploma course and they are now applying those principles, the osteopathic principles, into everyday practice. So it'll be lovely to hear from you, and I hope you get something out of this today. So forgive us for the language that we use. We're trying to be student friendly so that it does make sense to osteopaths who may be hearing some of this terminology for the first time. There's loads of materials out there for you. And while I've got your attention, I'm going to give you a couple of dates for your diary. I should have pulled them up, right? But I wasn't that intelligent or quick because I've come straight out of practice too. October. October, we have got our web fronts. I can't pull them fast enough. If anyone knows the date, Rob or Ben, please share. We've got our web fronts. We've got a team of wonderful osteopaths. Ben's one of the speakers, actually, that's going to be chatting and talking. There's going to be so much to learn. So please, you've got an email landed in your inbox soon enough. The date has gone through my head because I juggle a lot
5th
of
of
dates.
September, Pindy.
Is it end of September? Oh, here it is.
5th,
Here it
5th,
is.
yeah.
5th of September, not October. I've mixed up another event for that. 5th of September, we have got our web fronts. So an email has landed in your inbox. You can book the tickets. Ticket tailors all set up and open. If you haven't seen that email, don't worry, there'll be more coming through. October, we have got our 2-day breast course. This one is aimed predominantly for the female practitioners, first of all, while we do this first cohort. And it is for those who are a little bit more experienced in applying these principles into everyday practice. So if you've seen that invite loaned into your inbox, click on it, join the 2-day conference. It's going to be amazing. It's actually a hands-on workshop, okay? It's not a conference. Now, we've got Ben Adams here with us today. If you do not know Ben, he's also a practicing osteopath, graduate of the postgraduate diploma course in classical osteopathy. He's very, very active within the ICO, within Osteopathic Alliance, within the General Osteopathic Alliance, Osteopathic Council, and lectures all around the world. So you're in good hands tonight. We've also got the team of ICO in the background, and they're going to be sharing bits and pieces in the chat box with you. And Rob's joining us tonight as well. He's the chairman of the ICO. So if there's anything that you'd like to ask him towards the end of this talk tonight, feel free to do so, and he'll be more than happy to answer. So without further ado, let's crack on. Handing over to Ben. Thank you so much, Ben.
Okay, bear with me 1 second whilst I share my screen. Okay, bear with me. There we go. So, good evening. As been said, my name is Ben. I am one of the sort of senior lecturers at the ICO. And today I would like to take the opportunity to engage with you in some sort of clinical discussion, really around a case history from a real patient I've seen in clinic, and to explore and extrapolate the way that we think in classical osteopathy and how that's useful without any of the language or that kind of thing, which might seem a bit opaque at first. So, for those classical osteopaths that are watching, there will be a slight difference in the language that we use and that kind of thing. So, um, why studying classical osteopathy changes your thinking, your patient relationships, and your practice. And for me, I graduated in 2008. I started studying with the Institute in 2010, and it really has transformed my practice over those years. And what we'll do is we'll have a look at this patient and see perhaps why or how it has transformed my practice, and can do the same for you as well. So, I would like to take the opportunity to talk to you about a man in his 50s with 30 years of back pain. Now, this was 30 years of having pain at night, from the lower leg up to the head, pain across the suprascapular region. He didn't have any neurological symptoms at the time, but he did have a cervical disc prolapse 10 years earlier, which had given him left arm symptoms, so a bit of radiculopathy and things. Importantly, the neck pain started soon after a high-speed car crash. Now, one of the important things to note is actually the car rolled. So this means the mechanics he went through, the forces he went through, would be, say, quite different to if you had a head-on collision or you had someone hit you from behind. It was also high speed as well. So when we're asking questions about how things have happened, it's really important to get a sense of a whole kind of picture as to what's gone on. And the reasons for that I will explain a little bit later. So this gentleman had heard it all. As you'll hear in a little bit, I met him at a business meeting, and he had seen everyone, done everything that you could imagine. So he'd seen osteopaths, chiropractors, physiotherapists, had steroid injections. He even had surgical de-innervation. So generally, throughout all of that, the treatment his pain would drop from 8 out of 10 to a 2 or 3, but it would only last for a few weeks and then it would come back. And uh, to say he was skeptical that I would be of any use to him would be to underestimate it. You know, he'd had years and years and years of this cycle, and he was in significant amounts of pain. When you see someone who has been in long-term pain for a long period of time, they have this look to the face where they're slightly anguished, and he definitely had that, and it was disrupting his sleep. So he would go through periods where he could barely sleep at all, um, and he was at his wit's end with it, basically. So I met him at a business meeting and I said, "Oh, that sounds interesting. I might be able to have a look at that." And he kind of ignored me for a few weeks, and then he came back to me and said, "Oh, you said you might be able to help." And so we sort of gradually started treatment. And uh, what this is about is what I first found and what changed as I treated it and the results of that. So he was stuck in what I like to call a symptom loop. There's probably a more fancy name for it, but we'll go for symptom loop for now. So the pain would go up, he would see someone, pain would reduce temporarily, a few weeks would go by, and then the symptoms would return, and he was stuck in this cycle. And the issue for that is that obviously the pain remains, and you get this sort of fluctuation of symptoms as it goes on. But no one had really, from the sounds of it, and seeing this loop and seeing how he was, no one had really got to the bottom of why. So he'd seen doctors and been told he had uh, wear and tear or arthritis of the neck, and basically steroid injections and de-innervation were the only things available to him, which he tried and didn't find successful. Um, and was told that was kind of it, really. And but when I looked at him, I had a slightly different take, a slightly different approach. What classical osteopathy gave me was that different approach. So an important thing to say here is there's not a magic technique I'm going to talk about, or the one, magic bend technique or something. It is that way of thinking. And how we look at the patients that makes the difference. So I didn't manipulate his neck at all. In fact, I barely touched it for weeks. And he was looking at me as if I was from Mars. You know, um, I'm coming here with neck pain. You're treating my pelvis. You know, it's my neck, right? And yeah, yeah, I know. Very, very little direct work. Okay. And from his perspective, it was quite gentle. You know, there was no pain. I wasn't doing any harsh soft tissue stuff. And he was, so it was very, very different to what he'd experienced before. So, why was it different? Well, I wasn't aiming to look at trying to treat bits of stiffness, and this is key. It wasn't about that bit doesn't move, so I'm going to try and move it. Okay. What we are looking at is trying to understand the forces behind what's going on. Why are things like they are? You know, what has that body been exposed to that gives the environment that results in the symptoms that we see, rather than saying the end result of these symptoms, and I can see that it's stiff or that is inflamed, and I'm going to treat that local area. So it's another way of looking at it. It's a different way of seeing a patient, and that for me is key key difference about classical osteopathy. Not necessarily the hands-on stuff, really. Okay. So when I first looked at this guy, the spine felt traumatized, and there were significant issues with the global mechanics. So, when I say global mechanics, what I mean is the whole body. So, how the whole body holds itself in space. And there were issues with how that was. Okay? You could see that the anterior-posterior curves, those front and back curves of the thoracic and lumbar spine were very flat, and same in the neck as well. Often this happens where you have someone that's experienced trauma, like a car accident. Over time, you get a flattening of the AP curves. Now, if you remember, what I said earlier was it's really important to understand the mechanism of exactly what's happened. And he'd been rolled, which means his spine had been exposed to traction, as well as the usual sort of forwards and backwards movement. He had been suspended in the car as well. So that would also affect several points of the spine. And this is what we see in this guy, which I'll come on to in a minute. But there was also a lack of spring in the spine, a lack of that just slight elasticity and give, okay, that we generally get. That wasn't there. That way it was like touching like wood, or like almost like rock, really, and extended through the whole spine. So what we had was a guarded and a compressed quality to the whole spine there. So you can see the local findings, which I'll come on to, are important, but they're not the whole story. So even before we've looked really at the neck, got an idea of what that whole spine, the quality is, and how the whole spine has responded to that trauma experienced and adapted to over those decades as well. Now, when I was talking about that feeling of health, you may have noticed that I sort of highlighted a word called trophicity. Now, trophicity is a concept that we talk about in osteopathy, and classical osteopathy in particular. What we're talking about there specifically, we don't mean sort of trophic changes around the bone per se. What we're talking about is the trophic flow through nerves, which is essentially CSF outflow through the spinal nerves, perineural outflow that contains nutrients and things. And this is an old osteopathic concept. So when you read in the old books, very often when they talk about trophicity, they are talking about this. However, it can be very confusing reading the old books because some osteopaths will talk about this, and then as time goes on, there's a gradual switch to talking about bony change and that kind of thing. So if you do read the early osteopaths, you've got to be careful with words like trophicity and really understand what we mean when we talk about them. So when I talk about trophicity in this instance, I'm talking about that that vitality, that sense of health, and that specifically that perineural outflow through spinal nerves, which is some very interesting modern research on proving a concept that was first talked about over 100 years ago. So the base, the foundation, the what are we talking about when we're talking about the spine as a whole and global mechanics? Well, when we talk about the foundation or the base of the mechanics, very often in the global sense, very often what we talk about is the pelvis, right? And what you could feel in this guy is significant strain in the pelvis, particularly around the left sacroiliac joint. And you can see in the picture there is actually different directions of fibers of ligaments within the sacroiliac joint. And it's both the oblique and the vertical fibers that were there's an awful lot of tension around, and you could feel bony changes around the SI there as well. So that would be the mark, what we call plastic change. Um, so changes to the ligaments around that left sacroiliac joint, as an example, but part of a whole. So again, whilst there might be local findings in the sacroiliac joint, we'll always go back to look at it in terms of regional and global mechanics as well. So there was strong tension around the left hip there, and compaction through the lumbar spine. Pindy, just to say, I can't access the chat. So if anyone's asking me a question as I'm going, I've lost my mouse, so I can't see. So I'll just continue this slide, and then if anyone's asked a question, can you let me know? So there was uh, there's strong tension around the left hip, compaction through the lower lumbar spine. So before there was really a neck issue, there was a base problem, a problem with the foundation, if you will, there. Yeah. And so even without looking at the neck, we've got issues what to think about there. Okay. Pindy, sorry to interrupt you there. Are there any questions for me or anything?
Not at present, but I will grab your attention.
Amazing. Thank you. Right. So there was a lot of what we're going to call torsional strain. So where we have an element of rotation, okay, like a torsion. There's a lot of strain in the area of around T9 and T10, right? And it was quite evident in the spine as well. Now, for other reasons, mainly to do with anatomy of the joints and things around that area. This is something, again, that you typically find with patients who have been through physical trauma in this way. Another thing that we found is that T3, T4 were held anteriorly relative to the other parts of the spine. And what this meant was there's a lot of contracture around the shoulder blades, around the periscapular muscles, and up into the upper fibers of trapezius and the nuchal ligament as well. So then locally, what you noticed was that C5-6 very, very compacted, and the OA was sort of held and compacted in this part of this pattern as well. So there was a lot of tension in trapezius and scalenes on both sides as a result of this wider body posture. When someone loses their AP curves like that and have done so over a period of time, decades in this case, what happens is very often these muscles themselves become postural, they become structural, and they lose that sort of elastic element of a muscle because they are performing a different function. It's not that they're wrong, they're performing a different function. And these findings of areas of strain or increased tension does not mean that I'm then going to go and hit those areas. Okay. Um, but it gives me an idea of the pattern as a whole throughout the body. So, what does this mean? Excuse me a second whilst I have a slurp of some water. So, you may have seen that image there on the right hand side with the lines and what they mean in terms of polygons and things. Now, I'll be honest, when I first studied classical osteopathy, I really didn't understand what they meant for about 6, 7 years. Um, they were a theoretical concept, and they look very scary, and they can seem intimidating, but they're not. They are really once we delve into them a little bit more, we find that they're really useful and give us a really useful framework. Um, what that framework does is it allows you to look at the relationship between the pelvis and the neck at the same time. Okay, so you're not separating the two things. You're looking at treatment at the same time of the whole body. Understanding how the forces going through the spine, through the body, are behaving. Um, and also what forces different parts of the body are exposed to. Now, if we're looking at global mechanics in this sense, you could kind of get a sense that some areas are going to feel like they're under a lot of strain or a lot of stress. That there's going to be localized areas of high amounts of force relative to others. But it's important to see that that's not in isolation, that there are going to be other bits. Okay. And that whole pattern is what matters, not the one bit. Okay. Because if I let's say I go and I try and treat that T9 that I was talking about. Well, if you've got this idea of lines of force and things, you can just see that if I do that, it's just going to go back. Yeah. It because it is responding to the forces going through it as the body is as a whole. So we have to understand these underlying forces and try and appeal and work with these forces to allow the mechanics of the body to change. Okay. And this is where the concepts of classical osteopathy really, really useful in this case. Okay. Because if I hadn't gone through the course, if I hadn't studied classical osteopathy, I would not have the skill set to help this patient. 110%, without doubt. It is those concepts that really help me with this patient. So, the classical lens, okay, talked about global mechanics, how the whole body is organized. Regional. So we're then looking at, okay, what is the lumbar spine doing, or the thoracic spine doing, or the neck doing? Okay. And then local, what is happening at that segmental level, right? And the ability to look at different levels and to focus on different things, and to get those different viewpoints. Again, that's part of the classical viewpoint, right? And each view from if you zoom in and look close, or you step back, or you step way back and look at the whole body, they all make sense of each other. Now, it's not that a segmental thing happens in isolation and therefore but you can't make sense of the global picture and things. You have a sense of how one relates to the other and vice versa. Now, in classical osteopathy, there's this idea of stabilization. What that means is you work with the patient, and gradually the mechanics get to a point where they can hold, where the patient can no longer experience his symptoms, but crucially, they don't return. And this is what is called stabilization. And it's a period where the mechanics essentially have become more efficient. And what we want to do, our way of working classical osteopathy, is essentially to stabilize all our patients. And in some cases, if you take that local approach, if you say, oh, okay, I'm going to go after that C5-6 or that T9 or that left SI, okay, because that's still a local approach, even though you're looking at the wider mechanics. Yeah. If you do that, you start working locally too early in that way, or inappropriately in that way, you may get a change that can't hold, that can't stabilize. Okay. Now that's not a technique issue. That's the way we think about it, the way we look at things. So in this case, what would that mean? So I looked at the soft tissue. Okay. Now, uh, what do I mean by that? I'm not talking about doing soft tissue work or effleurage or massage or inhibition or anything like that. Okay. What I'm talking about is looking at the superficial tension, or more correctly, the tension through the superficial tissues first. Why? It is tempting to look and think, oh, that joint is tight, I'll make it move, or that muscle is shortened, I'll lengthen it. But we've got to look at that, the tension going through the wider patterns first. What that does is it allows a correlation to happen between the muscle and the fascia, okay? And then the muscle and the spinal joints, for example. So here you've got a picture. You can see there are layers to the fascia. Okay, there's a superficial layer that sits within the skin, and then there are deeper layers, yeah, of the fascia. And you've got to gradually work with these, and then that starts to appeal to the epimysium and the perimysium. Yeah? So you're using that connection in this case through the fascia into the muscle, into the spine. Okay. Now, what that means is that you start to get more movement that can be held within the body, for example, or a better, what we would call an improvement in coordination or a change in coordination uh, of movement through groups of vertebra. Um, we can call groups of vertebra that move together. We might call them arches, for example. So we can have different arches that we work with, and you can start to see a change in these things. Right? So the aim is better tissue correlation, better coordination of things like movement and that kind of thing. Okay, to gradually start to stabilize the patient there. Now, when I say better, it can be tempting to think, well, I think what that pattern is wrong. What I'm saying is that you get a change in that whole pattern of movement. Okay. And what you see as a result of that is a change in the quality of movement that occurs typically in the global level or regional level first. Okay, so it typically occurs in the global or regional level first. What that allows is for those more efficient mechanics to gradually stabilize. Now, if that happens, what you'll gradually notice in the patient is that the pain will subside. They might get new pains that they had. Typically, they say, "Oh, I had this pain 10 years ago," and something like that. And that gives you an idea that those underlying forces that you're looking at in the body have begun to change. And what the body is doing is holding, because you are starting to see the emergence of older mechanical patterns. Only when have you seen a change in the global and regional mechanics? Only then does it make sense to start looking at the local mechanics and things. So that would be the point where I would start to look at his C5-6, for example, or his upper neck. Yeah. And when I say look, I don't mean isolate that movement in itself, but using long lever techniques and things, because the long lever techniques generally help with coordination and the correlation that I've talked about. Okay, so I'd like to talk to you about one of my favorite, no, correction, my absolute favorite ligament. Yeah, the nuchal ligament. Okay, now why is it my favorite? Well, because it is a ligament, but it's also the blending of the tendon of the upper fibers of trapezius. And it's got a fascinating role in neck mechanics. Okay, so as tension and things changed, you start to get a slight, just healthy, natural traction through the neck from the tissues holding. Just enough for the change of movement in the regional mechanics there. Okay, so again, I'm not trying to push or pull things. I'm understanding mechanics and seeing how things change over a period of time. Okay, so this is more about stabilization and how using this concept you get that change in global and regional mechanics that stop feeding back into those local mechanics as much. Okay, so slow early work can help there, and that's what allows that result to hold. Okay, and the timeline is important as well. So not just how long have those forces been there, but how long have the body been adapting to the trauma that it had experienced, and how that adaptation had occurred waves throughout the spine. And I think one of the things that is often missed by osteopaths is the sort of the effect of time on the body. So what having had something happen 20 years ago, the effect of fibrosis or shortening of muscle or those sorts of things over a period of time. Because in that case, you cannot go delving into the local area. So one of the things that classical osteopathy gave me is the ability to communicate these ideas with my patients. So I could explain the finding to him and show him what was changing, and importantly, how things were changing between treatments. So this meant that he would sort of stick with the program and then could see changes occurring as he began to stabilize. Okay? But one of the key elements of it is a soft skill, because we often think about technique or we think about tools in the toolbox. But I actually think that can be a mistake to think of it in that way. You want to think about those soft skills like communication and things, and really the the skill set that classical osteopathy gave me included the ability to communicate local, global, and regional changes to my patients, which is invaluable in practice. Really, really is. Oh, complex patients rarely resolve quickly. Okay? If the patient understands your reasoning, they are more likely to work with you to the point that they stabilize. And this helps build relationship with the patient and trust. It also, to be blunt, helps build a patient list because if you can stabilize them, they are much more likely to refer people to you. Um, because you have resolved their symptoms over the long term, they don't just keep coming back. And that again is a key difference with classical. Okay, so why do I why do I think classical osteopathy is worth studying? Well, it gives you that bigger map to play with. It gives you the reasoning for difficult cases, and it stops you chasing symptoms. Um, it helps you explain whole body treatment without sounding vague. So it gives you precise language around what you're doing, and you can talk about that global, regional, and local effects to the patient, which more often than not will actually correlate with what they are experiencing. You can explain their symptoms to them. And it allows you to explain why things are reoccurring. Uh, Again, that is a huge thing. You can say why it's happening and what the different relationships are in the pattern of their body movement that they're experiencing. It's invaluable, really. What do you need to understand this? Well, really, what I've talked about is mechanics from different perspectives. So the way the body behaves, the way the body moves, from both a local, regional, and global perspective. An understanding of different qualities of soft tissue. So something I've not really gone into would be the idea of how differences in lymphatic congestion and venous congestion can affect the musculature, can affect the ligaments, um, and the relationship with those superficial and deep tissues of the body. So the relationship between the superficial and the deep elements there. Then there's the role of pain sensitization, the role of the sympathetic nervous system within that, and the regional organization that you often find, or you do find, within the autonomic nervous system, and how that relates to the threshold of nociceptive triggering and all that kind of stuff. Lastly, lastly, long lever techniques. Okay, so all of that, all of that you have to know before you come to the techniques. Okay, so people have to say to me, "Oh, classical osteopathy. Yeah, I've done GOT. I've done body adjustment. Okay, great. It's not that. It really isn't. Um, it is the last thing you think about. Right? The way we teach technique is about understanding from that point of view, from all those things I've talked about before we even touch the patient. And I cannot emphasize that enough. If you think it is a technique or another tool in the toolbox, you've got the wrong end of the stick. Right? It is that change in viewpoint that makes the difference. And how we do that, then the technique follows naturally from that. Okay. So the last thing we look at is those long lever techniques. And why long lever? Well, you avoid irritating local tissue. You've got chronically sensitized tissue. You cannot delve in there with short lever techniques or heavy soft tissue work. Okay. You've got to be careful in the way you approach it and listen to the patient in terms of pain to allow that desensitization to occur. You also have to treat the whole body, right? Because the sensitization, well, obviously it's centralized. So you have to bear that in mind when you're treating as well. Fascinating stuff. Love it. Lastly, and most importantly, this is Simon. So Simon is the patient who I saw, and this is his story. Now, important to note is that he has had many decades of pain, and you will get there's a sense of frustration that he has there. And so just bear that in mind when you hear him talk. But I think it's a powerful. So I'll ask you questions on camera anyway. So, how did you first hear about Alan's osteopathy?
I met Ben at a networking event in Letchworth. So he said he was an osteopath that helped with long-term pain, and I was going through some of that. So
Ben, I think the sound has gone.
issue with my neck ever
Oh,
since.
there it is. There it is.
Can be extremely painful to mild, but it's constant, and I have had various treatments over the years in relation to it. And so I thought if someone could help with long-term pain, I would give anything a go. So tried about another 100 things.
Okay. And what changes have you noticed in starting treatment?
Huge changes. I have very little issues with my neck, if at all, over the last sort of probably 6 months, which to me is an absolute miracle. And yeah, the treatment's been absolutely incredible.
Did the treatment meet your expectations?
And some, yeah. Yeah, and some. Yeah, no, on a serious note, I've probably seen top doctors in England about the neck problem. I've been told I've got arthritis, it will never go away. I've been told that twice by 2 private doctors, spent thousands in steroid injections, consultants, MRIs. So it puts a fast to a lot of that, which I find deeply concerning. But at the same time, it doesn't really bother me because I found the cure. So it's hugely important that people see proper professionals, really.
Okay. How would you say that we're different from other practitioners that you've seen before?
I've seen loads of osteos. I'm probably an osteo professional. I've seen like 20 probably, chiropractors. What everybody does is they fix the problem for you to leave the treatment room, and at some point in the coming weeks, you'll be back on the treatment table. It was a process with the osteos I was with. Was you go in, they crack your back, they sort your neck out, they realign your body, send you away, and then your pain goes from 6 to sort of 2, 3, stays 2 or 3, so it builds up to 6, 8, until you're feeling it too much, and then you end up going back to the osteo. So it was a cycle every 3 to 4 months, continually for about 5 to 10 years. Whereas this is dealing with the understanding the problem and then actually managing treatment being done to ultimately end up with a cure. And I've got to be perfectly honest, I really didn't believe a single words that Ben said when he told me that he could cure it. I was like, yeah, of course, I've heard that all before.
Would you recommend Adam's osteopathy to others?
No, massively, yeah. Well, best osteo I've ever seen. Go and see him before his prices go up and he realises how good he is. So yeah, no, I recommend him to everybody I speak to. I chat about where the neck issue comes up. There's your name comes up with Ben. It's incredible what they do. So highly recommend.
What's the most surprising thing about your treatment?
That I saw top doctors in the country in London clinics, and they never diagnosed any treatment plan that I've had, and I find that very, very, very concerning and weird that they wouldn't have said to me that this is an issue that can be resolved without the need to put steroids in the neck and all those things that they've suggested and kill off nerves. And so I find that very, very strange, to be honest.
Brilliant. Okay, so that's Simon there. You can hear that element of frustration, but I think for me, he's an example of the reason why I'm an osteopath, the reason why I love what I do, and the reason why I love classical osteopathy, because I said without the skill set I learned that there's no way I'll get anywhere near being able to help him. So I hope you find some of the things I've talked about there useful. Again, like I say, try to avoid some of the language that we use and things. So if you have any questions for me, please let me know.
You can tap the questions in the chat box and we can read them
Oh
out
yeah,
to Ben.
sorry.
None have come through, but I'm sure people are typing. And if you'd like to have your mic switched on, just put your hand emoji up and we can switch
Okay.
that on as well.
So how
Thank you
long
so
will
much, Ben. That
always
was absolutely lovely. And absolutely perfectly aimed at our student guests that are here today. Now, there's about 30 of us, and we just left. There's 29 of us. So we got a whole variety of experiences here. So please feel free to take advantage of this situation and ask the questions, the pressing questions that might, you want you to discuss and then we'll do it. Or just a question about what Ben said today. Pop it in the chat box and we can chat. Ben's one of our lecturers on the diploma course. We've got Alice in the audience, is also a lecturer. Rob is the chairman of the ICOB, also lectures as well. And I think he does a couple of the days on the diploma course. And then me, I'm an ex-student, and we've got Suzanne, who's an ex-student. So quite a wealth of information here. And while you are typing away, Ben, do you mind if I just go through the dates again? Because there's a few
sure.
people that have joined us that weren't here at the beginning. Those who missed it at the beginning, a couple of dates for your diary. Right, first up, this webinar was aimed at the students on our email list for student osteopaths. We will do another one again in 6 months' time with a new case study. So look out for those emails and invites. They'll be coming along. But in the immediate future now, so on the 5th of September, we have got our webference. Now, our webference is our conference that we host online. There's a huge team of us, okay? There's a huge team of us. There was a team of us working on our phones while Ben was talking, and we chat almost every day on our WhatsApps and organize events. So when we coin cute terminologies and words like reference, we run with it just for funsies. So entertain us. On the 5th of September, we have got a reference. And Ben will be talking on there as well. We've got a host of wonderful lecturers that are going to be talking about a myriad of titles, and that's a good one to attend. The diploma course that we're talking about here, and Ben's mentioned a couple of times, that begins on the 9th of October. That is the first weekend. So you do need to register kind of soon-ish. Don't sit on it, okay? If you're thinking about joining us, just click on the link. But Ben's got a QR code coming up and there's a link in the chat box. Just sort it out today. Job done, boom. 3rd of October is 3rd and the 4th of October is the weekend 2-day event for the breast course hosted by Louise Adams, Ben's wife, and Sandy Antunes from Canada, also one of the lecturers. Now, this is a very hands-on 2-day event. We are going to be touching breast tissue, each other, breast tissue, examining, treating techniques. So it really is aimed for female osteopaths that have done the diploma course already for this first cohort, and it will be opened up for a larger audience in the future. But just appreciate that it's quite an intimate course. So at the moment, we're just welcoming female osteopaths. So questions. Right, Ben, you ready? Okay, Suzanne, let's know, how long did you work with this patient before you saw a significant improvement? Ben, I think you're muted, mate.
Yeah.
Oh, there you
Yeah.
are.
So how long did I work for significant
With this
improvement?
patient, yeah.
Yeah. So I would say I started to see improvement in general mechanics and things like that at around about week 3, week 4. However, it was about 2 months before I started to see real change in the symptoms. And about 4 months before the pain dropped to virtually nothing. Not necessarily weekly throughout that period of time, but as a whole time frame, that was how long it took. I've got access to the chat there. So, Suzanne, first of all, does that answer your question? Yeah. Okay.
Right, unmute myself. Yes, yes, it does. I was interested to know that. And then actually, Ben, another question in terms of the way you worked with him. Did you always do a full body or just adjustment? So really working globally with each treatment, or did you tailor the treatment somewhat? Does that make sense, that question?
Yes. Yeah. So for the sort of student listeners,
Yeah.
often when we talk about body adjustment, what we're talking about can be a routine. So a way of working. However, I would take the view that it's more of a philosophy or a principle, and it doesn't really matter what position the patient is in. So I would say, but in terms of doing the routine in that way, yeah, I started the supine as we tend to do. Um, but I would typically do some more side lying type work because prone was quite tricky in the beginning. But again, and sometimes I couldn't do that because without wanting to go too complicated, because of what was going on in the lower thoracic region there was quite a lot of reactivity in the lumbar rectus spinae and quadratus lumborum as well. So issues were occasionally to get a little bit of spasm in those. So sometimes be quite acute presentation as well. But importantly, acute on top of that chronic underlying pattern that we saw there. So yes, a little bit, but now I would do more of that routine that I would recommend body adjustment for sure. Yeah.
Yeah, understand. Thank you.
No worries. So
Dan's on it. Dan's on it. She's answered.
excellent.
Reese has a question on clinical reasoning. We'll drop down to Reese.
So, when you treat structures away from the presenting complaint rather than local issue itself and see an immediate change follow through to the distal presenting area, how much weight do you personally give that as confirmation you found the driver versus short-term neurophysiological response? Do you always reassess later to confirm it holds? So, I'll take that in two parts if I may. So, first of all, do I always see an immediate change? Uh, to some degree, yes. What sort of reflex change you see occurring that can differ substantially. So if someone's had something for a long period of time, I wouldn't necessarily expect huge changes in the sort of more structural tissues. What I might look for in the beginning, again, without wanting to get too complex, is sort of changes within the fluid systems first. An element that I haven't touched on, but is key to this, is that the element of sort of lymphatic and venous congestion that often follows things like fibrosis. There's the effect on those deep and superficial layers of fascia that I talked about there. So yes, you would often see some sort of change. It's what the quality of that change is in the beginning that is different. Over time, that becomes more embedded within the soft tissue, more embedded within the sort of a more sort of ligamentous structure, as it were. How much weight do I give that? Again, I'm not necessarily looking for a single driver. If you have a person who has had evidence of sensitization occurring over many, many years, you are unlikely to find a single driver in that sense. But I will always look for changes, what changes I see, and how those changes progress treatment to treatment, and then over a grouping of treatment, typically 4 to 6 treatments, but then reassess. What I'm typically looking at is changing those global and regional mechanics that I talked about. But it's important. I'm not looking for a sort of key insult to the body or what it used to be called like a key lesion or something like that as a single driver. It's more a confluence of various different things, very often multifactorial. I hope that makes sense.
Thank you.
No
And
worries.
Alice has added a lovely comment to that as well, Ree. So have a little read of that in the chat box. I hope that didn't seem rude when I skimmed through. It's just Sian had answered everyone's questions. So I'm so sorry if that felt like I just kind of jumped on everyone. Thanks, Andrew. Lars, I hope that answered your question about how to find classical osteopath. Vish wanted to know how long you've been in practice, Ben. So I think I went to school with Vish as well. So that's the Vish I graduated with. Hello, Vish.
I've been in practice for since 2008. So what's that, 18 years?
Oh,
Barely.
that's a baby, Ben. Been 24 years now, so
Yeah, I had hair when I first graduated, and that was quite a while ago.
he works long hours, okay?
Yeah.
It's not stress, it's long hours.
Yeah. Yeah, studying classical doesn't turn you bald. No, no.
Fantastic. I think there's another question. It is, yay. Hey, Vish. We went to uni together. Oh, how sweet. What small world. Lovely to have you here. I hope you check us out a little bit more and check out the diploma. Um, if anyone has any more questions, please do chat away underneath.
Well, there's a
Monica,
question.
yeah, there is.
Yes,
Great presentation, really inspiring. Do you give your patients homework, i.e. exercises, practice, etc.?
yes, I do. The exercises that I give them depends on how they are. So, uh, for example, in something like this case, it would be very simple, very easy exercises to begin with, if at all. I might not give exercises for a little while because I want the body to be in a position where exercises can help. Very often, people have tried various different exercises, but the way they are configured currently means it's very difficult for them. So you want to allow them to be in a better place before you give them those exercises and things. But not always, not every condition is like that.
Was wondering if you issue a CPD certificate for this. Oh, sorry, Lars. Okay, yeah, that's a Sian question. Look, Sian is going to be sending out a feedback form for you all. Okay, she is the maestro of the ICO. Nothing happens without Sian's magic wand. So please fill in that feedback form because we are aiming to do a couple of these a year, as I mentioned earlier, and we can only improve upon them and give you what you need if you give us feedback. So this is the first one that we've done so far. We've got another one scheduled in 6 months' time. We can tailor that to suit some of your needs. If you tell us how we went today, how everything went today. CPD form, personally, let's just see what the institute say. I don't run the institute. Let's just see what they say. We'll figure that one out. I think that might be it, guys. What do you reckon? You had a little QR code, didn't you, Ben?
Oh, yes, I do. Let me just.
So Sian doesn't mind popping the link into the chat if it's nearby. Ben's got a QR code. Rob, did you want to say a few words before we wrap up?
No,
You
I
might
don't
not.
think so. That's been really interesting. Thank you very much, Ben.
Lovely. Any closing words, Ben?
I have to unmute myself, sorry. I thank you very much. It was a really great presentation. If you have any questions for me, or you have any questions, Roger, I'm more than happy to answer them. Any of the faculty be more than happy to answer them. Please do reach out to us.
We'll wrap it up and we'll see you another night. Take care, everyone. Good night. And thank you for being here. Bye.
Bye. Bye, everyone.